Bismillah. Only this much of students. Shall we start? Okay. Bismillah Rahman Rahim. See, one of the most confusing thing when I was doing MBBS, this hypersensitive reaction. Okay, and because they give lot of examples and some of the examples overlap here and there, so the confusion becomes very peak when I joined pathology, especially in immunology postings. It was more confusing, and treatment is same for all the diseases. Okay, most of the immunology diseases, the treatment is same and the doses vary, and there is no hello hello. Okay, so the confusion part is lies in diagnosing the disease. Okay, so that is very important. So diagnosing the disease sometimes, because this immunological reactions happens in infectious diseases also. Okay, that's why it is very important to decide whether it is due to hyperimmune reaction or whether it is due to infection causing reaction, because if it is an infection causing, it is morely curable. Okay, it is nearly curable in most of the infectious case. Okay, or we have definite treatment for it, and this diseases we have treatment, but we can stop the progression of the disease. Okay, we can slow down the progression of the disease. We cannot stop the progression, we can slow down the progression of the disease, but any of the disease will be there. Okay, that is the most important point you should keep in your mind. So that's why it is important to diagnose the disease, so to differentiate it from the infectious disease and from the whether it's autoimmune or hyperimmune reactions. So this is most important one. Okay, any of my dear, I'm recording, you can take this. So now you all know there are 4 types of reactions, right? You all know type 1, type 2, type 3, type 4. So you all know type 1, it is going to stimulate the cells to produce IgE. See, you should know what cells is going to stimulate and what cells is taking the antigen, what cell is going to present this antigen to what cell, and what is the interaction between that cell and the cell which is going to produce IgE. See, I am not telling the cell name itself here. Understand? So which means I'm going to ask you what is that cell and this cell. So which cell takes the antigen to the cell which is going to stimulate the B cell? Antigen present. What is the name of the cell? There are thousands of antigen presenting cells. What cell takes the antigen to the cell which is going to stimulate the B cell? You understand my question? Okay, antigen, mostly it is dendritic cells. They take the antigen and they go on present it to which cell? TH what? TH? TH2. Okay, so then it goes and stimulates the B lymphocyte. Okay, the interaction happens. Okay, then the B lymphocyte inside the switching happens. Okay, that is little bit higher level. So the switching happens, switching of genes happens. So automatically they release IgE. Okay, they release IgE. So this IgE is go and act on the which cell? Mast cell. It acts on the mast cell, and the mast cell immediately degranulates. So if the IgE, they need 2 IgE to sit for degranulation. Okay, so because the IgE should interact, 2 IgE will interact, then the degranulation happens. Okay, then because of this degranulation you get some effect, you get some effect. So because the granules inside the mast cells does these things, so they can cause bronchoconstriction. Okay, and they can cause vasodilation that leads to edema formation, and that leads to recruitment of the inflammatory cells, and they also cause increased secretion of the glands, increased secretion of the glands. So if it is a mucus producing glands, there is increased mucus production. So this can happen at the local level, or it can happen in the whole body, or it can happen at the whole body. Depends upon the power of the antigen, depends upon the antigen, the route, which route it is coming. Okay, if it is a bee sting, it directly goes to the hematogenous. Okay, it spreads all over the body, so it produces immediate systemic anaphylactic reaction, immediate systemic anaphylactic reaction. For example, hay fever, okay, it goes to the ALL route, so it produces immediate respiratory reaction. Okay, respiratory system goes for reaction. So or any drug, any topical ointment you are using, that area goes for reaction, that area goes for reaction. Understand? So these are the types of reactions seen in the type 1. It is very immediate. So why it is immediate? Because of degranulation, because of immediate degranulation. Understand? So because the mast cells already stores granules. Understand? So they need not to synthesize the granules, so that's why the reaction is very immediate. That's why the reaction is very immediate. Okay, so in bee sting, okay, the face and all will becomes like swollen. Okay, this is called angioedema. This is called angioedema. Okay, so sometimes in severe anaphylactic reaction, soft palate. In the anterior we have hard palate, then if you go to the posterior we have soft palate. The soft palate becomes edematous because of the anaphylactic reaction. So anaphylactic reaction means we say that we mean there is a massive vasodilation, massive fluid comes out, and edema. This and all background your brain should know, right? So then there is massive edema forming in the soft palate. So soft palate falls down. Understand? So it closes the airway. So this is what happens if there is soft palate edema. This is also common in the bee sting. Or sometimes larynx can go for the edema. Laryngeal edema can happen. These are all very dangerous edema to happen, so that will stop the breathing, respiration process. So this is very, very important. So we have to immediately intervene. So when we intervene, what we do is immediately we give a high dose of steroid along with very powerful bronchodilators. Very powerful. Same thing, we use it for status asthmaticus. Okay, because in the asthma the bronchoconstriction is on and off. It's not permanent. It's not permanent. That is the difference between other COPD and the asthma. It is a on and off bronchoconstriction. On and off bronchoconstriction. So in some individual the bronchoconstriction to be there for longer period. To be there for longer period. So those situation is called status asthmaticus. So immediately we give powerful bronchodilator, it dilates it. Okay, so this is the concept behind it. So just we want to open the airway and reduce the immune reaction. Reduce the immune reaction. That is the concept in type 1 hypersensitivity reaction. Okay, so if you understood this concept, you will never do a mistake. Okay, so this is the concept behind the type 1 hypersensitivity reaction. So in the type 1 hypersensitivity reaction, the antibody is IgE, the effector mechanism is mast cell. You know how the IgE is produced, and you know what is the effect happens once degranulation happens, right? So these are all related to the type 1 hypersensitivity reaction. Remember, one thing I want to emphasize here, any drugs can cause not only type 1, they can cause all the 4 types of immune reactions. Okay, so now let's go to the type 2, and you want me to write here, it affects the mast cell, then mast cells degranulates, then it produces the effect. So these are all we discussed now. And type 2, it is antibody mediated reaction, degranulation. Okay, degranulates. Okay, now antibody, mostly involved antibodies are IgM and IgG, right? Okay, now this antibody goes to the specific antigen, goes to the specific antigen. For example, this antigen is in the glomeruli. Okay, now we have a glomerular capillaries inside. So they have basement membrane, glomerular basement membrane. Okay, so the antibody goes to the target antigen in the glomerular basement membrane, right? So antibody is traveling and the antigen is fixed, antigen is static, antigen is not moving, right? Antigen is very specific, antigen is specific, right? Antibody is going there. So when the antibody is going there, then antibody binds with the antigen, right? Antibody binds with the antigen. The immune complex is formed at the site, of the antigen. Immune complex is formed at the site of the antigen. So immediately they activates the complement. Okay, so when they activate the complement, antigen antibody complex forms, then C1q comes, then automatically the complement pathway gets activated, then they produce the effect, they bring the neutrophil, all the inflammatory changes happens. Okay, this all we discussed. Even the video is available for the complement, you can see in the GU1 lectures, we have that video. Okay, now this whole thing happens, and the initiation happens is due to antibody produced against a specific antigen, which is static antigen, which is fixed antigen, okay. So any disease produced by this mechanism, it will be more specific systemic disease. It will be a specific systemic disease, whether it will be a renal disorder or it will be specific to that organ, it will be specific to that organ. Sometimes this antigen is not native to that. For example, see this antigen is, for example, a type 4 collagen, type 4 collagen, that is non-collagenous domain of the type 4. And lung capillaries also have same collagen, lung capillaries also have same collagen. So now the antibody is going to two places, right? If it goes to these two places, we call it as a good posture syndrome. We call it as a good posture syndrome. So another one is this antibody is going to the heart. Okay, we have heart valves, right? It goes to the valves. What is the disease? Say rheumatic fever, right? So here the antibody is not targeted against the protein in the valve, but it is targeted against the streptococcal antigen. It is targeted against the streptococcal antigen, but the streptococcal antigen resembles like a, so it is a cross reaction. It is a cross reaction. Okay, so now antibody going to the cross reactive antigen. See, what you have to understand, the concept here is antigen is fixed, static, and it's not moving. Antibody is going towards that side, antibody is going towards that side. So anything related to this, you will get mostly a single system disorder. Okay, a single system disorder. Okay, so this is the most important one, you should not forget in your life. Okay, so type 2 reactions, most commonly it produces a single system disorder. Okay, now even though here the complement is involved, the complement level will not go down, the complement level will not go down. Okay, now type 3, here this is the blood vessel, there is an antigen, and antigen antibody complex are formed in the circulation, this antigen antibody complex will go and deposit anywhere. They can go and deposit anywhere. So they produce multi-system disorder, okay. So the antigen antibody complex are in the circulation, so they call it as a circulating immune complex, this circulating immune complex can go and deposit in the any organ. Most commonly they deposit in the kidney, they produce circulating immune complex oriented glomerulonephritis, example PIGN. Okay, in the PIGN, what happens? Post infectious glomerulonephritis, there is an infectious antigen in the circulation, and the immune complexes are formed, and it is goes and sit on the glomeruli. Immediately they trigger the complement. Immediately they will trigger the complement. So in type 3 reaction, the complement activation is very severe. Complement activation is very severe, and that will leads to decrease in the complement level, especially C3 level will go down. C3 level will go down. So that is another sign that we are dealing with the type 3 hypersensitivity reaction. Another sign that we are dealing with type 3 hypersensitivity reaction. So SLE, another thing is, you can give example, systemic lupus erythematosus. So here the antigen is dsDNA. The antigen is dsDNA. Antibodies are formed against dsDNA, and the circulating immune complex is formed. They will go and deposit in many organs. They will go and deposit in many organs. Like another example we can show, like Hinox-Scholin purpura. Okay, so here the antibody antigen complex are formed. It deposits in the blood vessel, in the skin, and in the GI tract. So they produce multiple disorders. They produce multiple disorders. Okay, so one second before going to the type 4, because type 4 I'm going to deal little bit detail. So I'll just recap it. So type 1 hypersensitive reaction. See the antigen, the antigen which is coming for type 1 is, it is taken by the dendritic cells, and it stimulates the Th2, and they will again stimulate the B cell, because this T and B cell interaction is very important in type 1. Many research is going on in that side. Okay, so T and B cell interaction is very important, and that make them to switch over of the antibody production. They start producing IgE. They start producing IgE. So now we are going to, inshallah, the drugs are in trial. The drugs are going to come to stop this interaction. Understand? So now this IgE will go and sit on the mast cell. The mast cell degranulates. We see the effect. We see the effect. Okay, so this is maybe local or it may be systemic, and you know the outcome of the effect, right? So it depends upon the area and depends upon the, if it is systemic, the outcome is worst, right? So now coming to the type 2 reaction. Type 2 reaction, the concept here is antibody is IgG or IgM. Here the antibody is produced against specific antigen. Antibody is produced against a specific antigen. See, this antibody goes to that site because antigen is fixed there, and they go and bind there, and they induce the immune reaction. They induce the immune reaction. So they say like optimization and phagocytosis, all this and all they will say. Okay. Another thing is here, this antibody can also alter the function of the organ. Can alter the function of the organ. For example, if the antibody goes and sits on the TSH receptor of the thyroid cell, they will increase the thyroid hormone production. Graves' disease, they will increase the thyroid hormone production. Likewise, myasthenia gravis. You can give many examples. Okay, so why I'm not touching that example is next module is endocrine, so you will be knowing that. Okay, so now let us go to the type 3 reaction. Type 3 reaction also the antibodies are same, and IgG or IgM antibodies. The thing is, the concept is different because they form immune complex in the circulation. So the dangerous one part of it is they can deposit in many areas. They can deposit in many areas. They produce multi-system disorders. They produce multi-system disorders. So that's why example in SLE, the antibodies are deposits in many areas. Henox-Scholin purpura, the antibodies deposits in many areas. Okay. PI gene, you should not forget, it is PI gene is a planted antigen. It is due to planted antigen. Okay. So this is all the concept. Here the complement activates is C1q. Okay. This is for any the student wants to be very, for a normal student, because you are all Ibn Sina, right? So you should know more. Okay. So Yani, see, we discussed in the last GU1, there are three pathways of complement, and one is classical pathway where antigen antibody binds, immediately C1q activates, then the complement pathway, classical complement pathway activation happens. See, the C1q has a weird character, that is, it can also bind directly with the antigen. It can also bind directly with the antigen. That I didn't discuss there, but now you should know this. Okay, so C1q has a capacity to directly bind with the antigen. It is going against the principle, you understand? So that's why I told it's a weird one. So C1q goes and directly can bind with the antigen, and what are the different types of antigen they can bind, that I will go in the fourth year if I am coming. So this concept you should know. C1q has a capacity to go against the principle that it can go and bind with the directly with the antigen. Okay, these are all recently evolved things. So they can stimulate without antigen antibody complex. They can stimulate the complement pathway without antigen antibody complex. You understand? But what we teach normally, antigen antibody complex need to be formed to activate the C1q, right? But in some cases C1q can directly go and bind with the antigen without the help of antibody, then they can stimulate the classical pathway. Okay, this you should understand. Likewise, there are some antibodies, we think only antigen can activate the alternate pathway, right? There are some antibodies, okay, they can form aggregate and they can stimulate the alternate pathway. They can stimulate the, they become like antigen. They become like a abnormal aggregates. Okay, so this and all inshallah I will discuss. I don't want to confuse you much. So you understand this is about all these three different types of immune reaction. Now we are going to touch the immune reaction where the antibodies are not involved, where the immunoglobulins are not involved, where the B lymphocytes are not involved. We are going to talk about a immune reaction where only T lymphocytes are involved, where only T lymphocytes are involved. So that is related to the PBL. Okay. So now type 4 is called cell mediated immune reaction. It is called cell mediated immune reaction because here we are not talking about antibodies. Here we are talking about T lymphocyte. Okay. So we have two types of reaction. One is delayed type and cytotoxic reactions. So cytotoxic, it is by CD8 cells. CD8 cells, they produce direct cytotoxicity and it is very potential in killing the viruses, and viral infected cells they can kill directly. Okay, not actually virus, viral infected cells, they can be highly dangerous. The cytotoxic T lymphocyte knows that some cell is loading the virus, immediately they will go and bust them. So it is highly powerful one. Okay, when, but CD4 cells, they need they give, secrete something so that macrophage can do the job, so that macrophage can do the job. Okay, so this is very very important. I'm just going very colloquial so then I can go in slowly in more deeper. So you understand, so this is the basic concept you should not forget in your life. Okay, what are the names you can forget, but this is the concept because we are going to manipulate this process by giving drugs. So now it is a T lymphocyte, it is a CD4 T lymphocyte, it has different subsets in the CD4. Okay, they have Th1, Th2, Th17. Okay, so this Th17 plays a major role. This is recent advancement. Okay, so recent advancement is like 5-10 years, 5-6 years back. So it is Th17 which is mainly involved in Crohn's disease pathology. Okay, Crohn's disease pathology, so you should not forget it. Okay, now the Th1 and Th2 all are, we name it by different types of chemical substances they produce. Why we name it? Each Th1 has a its own identity of chemicals they can produce. Th2 has its own identity of chemicals they can produce. Th17 likewise. Okay, they have their own identity of chemicals they can produce. Like that, what chemicals they produce, they made them into subtypes. They made them into subtypes. Okay, now this, all these cells are involved in granulomatous inflammation. All these cells are involved in granulomatous inflammation. So you all know how the granuloma forms. We'll take a classical example, tuberculosis. We'll take a classical examples, tuberculosis. You all know this is a, not alveoli. Okay, so you all know the alveoli has alveolar macrophages, and you all know the TB comes most commonly from the aerial route, and if it comes, the macrophage takes it. So that is called phagosome, but macrophage cannot fuse because the Mycobacterium tuberculosis, they will not allow them to fuse. Okay, so yesterday I got a mail from a student that very very good question she asked regarding how T cell can stimulate nitric oxide in the macrophage? Okay, so it's a good question. I'll answer this. Actually, I mailed to her. Anyway, I'll tell now also. So you know this macrophage engulf the take the mycobacterium, but they cannot able to process it. So immediately what they do? They release, yeah, what cytokine? So interleukin 12. Then they go for CD4 lymphocyte. CD4 lymphocyte will produce what? Very important one. So interferon gamma. Nowadays, my dear, it is available as a drug. So interferon gamma plays a major role. Interferon gamma does three roles. I told in the respiratory module. What are their role? What are the three roles? They can recruit more macrophage. First point. Second point, they can go to the macrophage and stimulate them to go for phagolysosomal fusion. And third point, they induce the macrophage to produce a enzyme called INOS, inducible nitric oxide synthetase. INOS. Okay, this will produce nitric oxide. This will produce nitric oxide. Nitric oxide in the POD we discussed, it is a potent killer of microbes. It is a potent killer of microbes. Okay, so now the nitric oxide is poured on the, it is fully put on the mycobacterium, so it will be destroyed. All the mycobacterial wall will be destroyed. So then the fluid goes in, then mycobacterium will be busting. Understand? So this is what happens. Okay, so now this interferon gamma is very very important. Interferon gamma is very very important. Okay, so because they do three function. What are they? They recruit more macrophage, they induce phagolysosomal fusion, and they also induce production of INOS, and that will increase the production of nitric oxide. This is very important. Our mycobacterium is very clever. They will not allow them to produce INOS. Understand? So when the interferon gamma comes, that takes over. That happens. Understand? So that is a need of interferon gamma. So that's why in HIV patient, if there is no CD4, there is no interferon gamma, they go for dissemination of tuberculosis. Their tuberculosis spreads fast, or they get tuberculosis infection. Understand? So interferon gamma is very important. One more thing you should understand, you know, in rheumatoid arthritis, you know, there is a arthritis due to immune mechanism. In those patients, we give you a drug called disease modifying drugs. Disease modifying drugs. We suppress certain cytokines, so that will also leads to dissemination of TB. That will also leads to dissemination of TB. That cytokine is TNF. That cytokine is TNF. Now you all know TNF is a acute inflammatory cytokine, right? Acute inflammatory chemical substance. So here what is the role of acute inflammatory chemical substance? So now I am going to connect this chronic inflammation with acute inflammation, because so far we never discussed this, right? So there is, see, when we are studying separately granulomatous inflammation, acute inflammation, but actually both interact, both will interact. See, this CD4 lymphocytes has a capacity to secrete IL-1, and they also have a capacity to secrete TNF. Understand? So they can bring the support of neutrophils. They can bring the support of neutrophils. So that is also needed to kill the mycobacterium to form the caseous necrosis. To form the caseous necrosis. This area I didn't discuss so far. Okay. So this is also very important. So in type 4 hypersensitive reaction, in type 4 hypersensitive reaction, there is interaction between the type 4 and the acute inflammation process. There is the interaction between the type 4 and acute inflammation process. Once again I am telling, so I am taking example of tuberculosis. You know tuberculosis comes in the air and it goes to the alveoli, and alveoli we have a macrophage. Macrophage takes it, they cannot kill it, right? So why they cannot? Phagolysosome cannot happen. Phagolysosomal fusion cannot happen. Immediately they stimulate the T lymphocyte, and the T lymphocyte releases interferon gamma. This interferon gamma helps them to do three things. What are they? Yeah, recruit macrophage. Yeah, in most important thing now you should know is induce iron nitric oxide synthetase, and that produce nitric oxide that will kill the mycobacterium, understand, along with phagolysosomal fusion. And there is also interaction with the acute inflammatory process, so they can bring the neutrophil also, they can bring the neutrophil also, understand. So this is all happens in the granulomatous inflammation. Here in this case they produce caseating necrosis, so it is called caseating granulomatous inflammation, understand. There are some situations where they will not produce any caseation, but they produce a granuloma, they produce a granuloma, that is called non-caseating granulomatous inflammation. So example is tuberculosis, sorry, example is even tuberculosis, okay, I don't want to confuse. Example is sarcoidosis, Crohn's disease. Sarcoidosis and Crohn's disease are the example. It is a type 4 hypersensitivity reaction in Crohn's disease, but it is non-caseating granulomatous inflammation, it is non-caseating granulomatous inflammation. Okay, now when the person is having Crohn's, okay, what is the symptoms he have? He have abdominal discomfort, pain, diarrhea, altering bowel movements, sometimes constipation, sometimes diarrhea. Yeah, nausea, but most commonly altering bowel movements. It is very classical. People will think that he is having irritable bowel syndrome, some kind of irritability. So they have this kind of manifestation. When they come, so usually when you do a clinical examination, there will be pain in the right side or involving side, because usually it will be in the ileal cecal region, okay. So now after then they do all the investigation, right. Usually they do from lab investigation, serology to till scopy, okay, they do complete investigation like colonoscopy, all they do. When they do it, they they are not finding any clue, they are not finding any clue. This is the most commonest thing you will see, understand. And you will very late advanced stages of Crohn's disease, you will be seeing skip lesion, you see all those stuffs, okay. But in the early stage of Crohn's disease is not easy to diagnose, it is not easy to diagnose, it is the most troublemaking disease in GIT, understand. It is not now, and that too nowadays in last 5 years the Crohn's disease rate is increasing, understand. So it is most troublemaking diagnosis. So there is a lot of challenges involved, okay. So some of the challenges I will discuss, which is diagnostic related. See now I told this is a yearly Crohn's disease, this is a yearly Crohn's disease, okay. Now the patient is having, yeah. Yeah, that's not microscope. Now we didn't go to the microscope. In the colonoscopy, images, serology, lab investigation, nothing is there. Nothing, no findings is suggesting of anything. Understand? That means nothing means some. There is no any conclusion you can make. Okay. So when the situation is like that, so what we usually do is the patient is having intolerable pain and abdominal discomfort, and as well as what? And we don't call this as a biopsy. First they will explore the abdomen, okay, that is called laparotomy. Just they open up the abdomen, just they will see what is there, okay. So in this case they opened up the abdomen, they found ileocecal region, there are some ulcers, there are some ulcers. So usually they resect it, because since they open it up, they will not take biopsy, okay, they will resect it and resect that area, and they put uh, they take the specimen out and they will give send to us, okay. Then we do a sectioning and we see in the microscope. When we see in the microscope, I am seeing only non-caseating granuloma, I am seeing non-caseating granuloma, not transmural inflammation, no severity, okay. Only I see some granulomas in the submucosa, non-caseating granuloma. You all are able to comprehend, okay, non-caseating granuloma, okay. After that, okay, I will ask them to give all the clinical finding, I will ask them to give all the radiological finding, I will ask them to give all the laboratory serological finding. All are inconclusive. ANCA negative, ASCA negative, you know ANCA and AACA, ASCA, anti-Saccharomyces cerevisiae antibodies, all are negative. Okay, even it is positive. I will come to that case afterwards. Now all are negative. Only I see non-caseating granuloma. What I should do? Hmm? Mm.
When cascading granuloma, it can see from what's the lab.
Histopathology lab.
But
And a
it is
biopsy came to histopathology, so we did the microscopy and we found it's a non-caseating granuloma. See, my question is, if I see a non-caseating granuloma, what I should do? And clinical laboratory radiological investigation is not at all showing any sign. What exclude?
TB.
Yeah, what is the first thing I should exclude?
TB.
Tuberculosis, mashallah. So we should exclude tuberculosis, right? You should not forget in your life. Why?
Because TB is caseating.
TB is,
It says
but it is non-caseating.
so.
Then why?
In the first stage, it is
Mashallah, in the first stage of tuberculosis, it will be non-caseating. Okay, then only it will become caseating. That is one reason, right? What is another reason? What she is telling is, like, if you treat, what will happen? If you treat it like a Crohn's, what will happen? So it will disseminate, because Crohn's we put steroids. Okay, steroids should not be given in tuberculosis, right? So automatically it will disseminate. So in this case, what you will do? That's what my question. Mashal, you all know what you to exclude the TB. Okay, I excluded. I did all investigation, right? TB is negative. Okay, all investigation I did, TB is negative, but I don't have a guts to tell them to treat for Crohn's. Okay, even nobody will have guts to tell them to treat for Crohn's. Okay, so what to do? We ask them to treat for tuberculosis for 1 week or 2 week to see the therapeutic response. If the patient is improving, then we will tell them to continue TB, ATT, anti-tuberculosis therapy. Or if the patient is not improving, stop them, then treat for Crohn's. Understand? So this is how we should do, because even in recent articles, recent journals, the situation remains same. Okay, because it is not easy to diagnose Crohn's disease, early Crohn's disease. Understand? Okay, if it is a late stage Crohn's disease, it is easy to diagnose. Understand? So late stage Crohn's disease confuses with ulcerative colitis if there is no ileal component. Understand? If there is a very good small intestinal component, then we can easily diagnose it as a Crohn's disease. Okay. So now you all understand, no? It is affecting the terminal ileum or cecal region. That is also commonest site for tuberculosis. That is also commonest site for ileocecal region is the commonest site for intestinal tuberculosis. Commonest sites for intestinal tuberculosis. You understand why it is confusing us more. Okay. So this is the reason. One more thing I want to tell is, if the patient has any clinical features of Crohn's, I will tell you the epidemiology is very important. That's why I'm trying here. If it is a Westerner and HIV in Western people, any Europe or Americans, if HIV is negative, okay, and lung is clear, okay, there is no any sign of pulmonary tuberculosis, and he is taking pasteurized milk, he is not at all taking any unpasteurized milk, okay, don't need to suspect tuberculosis there. Understand? You can directly suspect Crohn's disease there. Understand? If the same person in India, okay, I will suspect the first tuberculosis there. Understand? Please keep that in mind. Whether India, Pakistan, Sri Lanka, or Africa, I don't know about Middle East here. So, but any tropical or subtropical countries, you have to suspect tuberculosis. Understand? Especially India, Pakistan, Bangladesh, Sri Lanka. If you're dealing with a patient like that, you have to suspect. You have to rule out tuberculosis. If you're dealing with the Americans or somebody, and if the person fits all this, HIV is negative, and is never taken any, nowadays nobody is taking unpasteurized milk, okay, maybe some camels here I see somebody is drinking, but even in India, some villages they take the fresh milk, okay, from the cow directly and they drink. So but now all are pasteurized milk, okay, so that's why we don't see much intestinal tuberculosis in this generation, okay. So because the TB dies there, okay, tuberculosis bovis, it come it the bacteria name is Mycobacterium bovis. Mycobacterium bovis. Understand? So this you have to keep in your mind. So which area you practice, which patient you comes, it's very important. Okay, in this inflammatory diseases. In inflammatory diseases. Okay. So now coming to the another most complicated part. If in a case ANCA is positive or ASCA is positive, it doesn't determine that the patient is having Crohn's. Understand? There are 50% of the cases ASCA is negative and the patient is Crohn's. Okay, there are 50% of cases ASCA is positive, the patient is not having Crohn's. Understand? So one of the finding added value is if you see Crohn's, if ASCA is positive, then okay, you can cool, like I'm dealing with Crohn's. Understand? So that's why in Crohn's disease especially serology has no value at all. Serological investigation has not have much value. So that's why Crohn's disease in diagnosis is based on clinical clinical, serological, radiological, and histopathological. It is based on all the integrated diagnosis. It is based on integrated diagnosis. So keep that in your mind. Inshallah, when I'm taking in MSK or I don't know endocrine who is coming, MSK or endocrine, the person who is taking, they will be dealing with again immune diseases. That time serology plays a major role. Serology plays a major role. Understand? Whether it is a type 4 hypersensitive reaction also serology plays a major. I'll give one example and I'll leave the class. So one is Hashimoto thyroiditis. Have you ever heard of? Hashimoto thyroiditis. Here it's a type 4 reaction, and here the lymphocytes are coming out from the blood vessel, and the lymphocyte will spoil the complete thyroid. The complete thyroid will become like a lymph node. I will show you when you come for the lab. I will show you we have good specimen. So the thyroid will have brown color areas. Okay, that will be become like a completely white color area. It will be become like a complete lymph node. Okay, so here in Hashimoto thyroiditis, you will not see any granuloma. You will not see any granuloma. So type 4 reaction can form granuloma as well as they need not to form granuloma. Understand? So granulomatous inflammation is an example of type 4. Is an example of type 4, and small lymphoid aggregates also they can form. Example Hashimoto thyroiditis. Hashimoto, they will not form a granuloma, they form full of lymphocytes. Full of lymphocytes. So granuloma means you see a macrophage, activated macrophage, Langerhans giant cell, right? But in the Hashimoto thyroiditis, you will not see it. You will not see it. Understand? Uh, I stop here. Any doubt? It's clear. See what all the things I discussed, I asked in the PBL. Okay, it is very. You will be seeing like straight to straight. You will answer. Okay, no confusion at all. Okay, and for the theory N block, yani like you study from Sylvester's handout. Okay, it is taken directly from there. Okay, so I think it didn't give case. Okay, no cases. Okay, I will ask him why he didn't give case. Okay, so you understand. So inshallah, do well in the exam. Don't be panic. Okay, our part is very small, minor part. Okay, and it's very well done actually. All the things Sylvester discussed, and I discussed here, and only PBL and this, right, MCQs. Okay, now coming to the lab, we gave one slide. Okay, and in the lab handout, I gave two cases, right? One case comes for the N block, one case comes for the N semester. But I don't want diagnosis. Okay, I want you guys to interpret the mechanism, understand what is happening there. Okay, that is more important. Understand that case. I hope you are all expert in those two cases because we already discussed in detail in GU1. Okay, so this is all about the examination. Do well in the exam. Yeah, yeah.
So what's the specific diagnosis
I
of
forgot
the
how to save this. Hmm?
إلا ده صراحة يعني في 1 و 17 دكتور